Now Harrison has actually now been talking a little bit about neuropathies and paraneuropathies, a very, very important group of neuromuscular disorders that has been coming up because identifying it is very, very important because your routine treatment of CADP is not going to work for your neuropathies and paraneuropathies. Okay, so usually it is all about rituximab. Okay, so no point in giving IVIG, steroid plasma exchange. It's more about rituximab. So now it's being actually considered as a distinct entity from CADP. And important antibodies that are implicated in nodopathies and paraneuropathies are anti-contactin 1, anti-neurofacin 155, and anti-neurofacin 140. Another antibody which is not mentioned here is anti-Caspar 1. So contactin and neurofacin 155 are IgG4 class, whereas neurofacin 140 is an IgM class. So the clinical features is a symmetric, distally predominant weakness and sensory ataxia with a postural and intention tremor. If the patient has an anti-contactin 1 antibody, they also might have a membranous glomerulonephritis or renal failure. If they have an anti-Caspar positive, they have a painful neuropathy. They also might have a painful neuropathy. And as I mentioned earlier, they are less responsive to IVIG but have a very good response to rituximab. Next is multifocal motor neuropathy with conduction block. So this is a slowly progressive motor weakness and it mimics motor neuron disease or an ALS. So that is why it's so important to do a nerve conduction study for all your patients with ALS. To look for an MMNCB. So here they might have a focal motor conduction block, not much of sensory involvement. It's usually pure motor. Again, the reason why we confuse it with an ALS or an MND. And it's upper limb more than lower limb, usually males. Anti-GM1 antibodies are positive. This is very, very important. Anti-GM1 antibodies are positive. IVIG is a treatment of choice. Plex and steroids are not very effective. In refractory cases, you can go for rituximab and cyclophosphamide. So remember, multifocal motor neuropathy mimics MND. Usually it's pure motor, upper limb, weakness, atrophy, focal conduction block in the NCS, and usually it responds well to IVIG. Next is POEMS, which is basically a myeloma-associated neuropathy. It's also known as Crowe-Foccart syndrome. So P stands for polyneuropathy, O stands for organomegaly, E stands for endocrinopathy, M stands for monoclonal gammopathy, and S stands for the skin changes in the form of thick skin, hyperpigmentation, hypertrichosis, and clubbing. Now let's talk a little bit about the myeloma-associated neuropathies. So myeloma-associated neuropathies are quite a varied group of disorders. It depends on what is the type of the underlying myeloma. Is it a lytic lesion? Is it a sclerotic lesion? So let's discuss. So when you have the classical lytic osteoporotic myeloma type, multiple myeloma type, around 5% of patients you will have a sensory motor axonal neuropathy. This is usually mild and slowly progressive and unfortunately does not reverse with the suppression of myeloma. Next, we have the osteosclerotic type of multiple myeloma. Even though it is a very rare cause of multiple myeloma, only 3% of multiple myeloma, this has a more stronger association with a neuropathy. It has a more stronger association with a neuropathy because 50% of your cases will have a polyneuropathy. And usually it is this osteosclerotic lesions which is associated with your POEM syndrome or your Crowe-Foccart syndrome. So usually it is a demyelinating neuropathy, resembles a CIDP. It responds to the treatment of myeloma. It's morely because of lambda light chains. It's refractory to the treatment of your routine CIDP treatment like CIDP and IVIG. The main treatment is treatment of the myeloma. And as I told you, it can be associated with the POEMS or a Crowe-Foccart syndrome. Next, monoclonal gammopathy of undetermined significance. So it's usually associated with IgG, IgA or IgM types of immunoglobulins. And the clinical features are usually an isolated sensory and a distal predominant symptoms. That is basically your DADS variant, of CAD. NCS is an axonal sensory motor polyneuropathy, poor response to immunotherapy, and usually it is because of an IgM kappa monoclonal gammopathy. The patients can have tremor, sensory ataxia, more common in males, and we already discussed anti-MAG positives. So always remember these key terms. DADS is with an MGUS. Usually it is an IgM kappa, and usually it's predominantly sensory, and your anti-MAG antibodies are positive. 4, response to therapy. 4, response to therapy.